dementia, not just Alzheimer's. Our presenter today is Lauren Weiss. She's the Educational Services Manager at the Alzheimer's Orange County. And so I'm going to go ahead and stop sharing my screen and I'll let you go ahead and share yours, Lauren. Thank you again
Okay,
for the presentation,
thank you. And now the fun of
the
sharing.
technology.
There we go. Okay, good morning, everyone. Thank you so much for joining us today. Today, we're going to be talking about the different types of dementia. We have over 120 different types of dementia. Today, we are going to focus on about 12, but it will be a brief overview because there is so much information. I have asked Rachel to share resources with you that take a deeper dive, and I will let you know what to expect as we go through. And as Rachel said, we'll answer all questions at the end, but please feel free to put them into the chat as they pop into your head. So first, we'll talk about dementia. Dementia is not a disease, rather it is a group of symptoms that encompass various cognitive impairments affecting daily life, behavior, and thinking, with multiple potential causes. And as you will see today, the part of the brain affected first determines what we notice first. So again, dementia is not the disease in itself, rather it is a group of symptoms. And we ask ourselves, what causes those symptoms? So for instance, if you had a headache and a sore throat, that wouldn't be the diagnosis. You're asking yourself, what's causing my headache and sore throat? And maybe it's a cold. And before we begin, I want to briefly touch on the importance of receiving an accurate diagnosis. For many reasons, people do not receive an accurate diagnosis. It can be because they fear going to the doctor, worry how a diagnosis will affect them, or feel that if there is no cure, what's the point of getting the diagnosis? However, an accurate diagnosis allows for tailored care strategies, better communication between the person living with the disease and their family and caregivers, and overall improved quality of life for the individual. We will review this diagnosis process later on, but I wanted just for you to keep this in the back of your mind, why it's important to get a diagnosis. And we'll briefly touch on Alzheimer's disease. Alzheimer's is characterized by gradual memory loss and cognitive decline that significantly impacts daily function and quality of life. Alzheimer's disease is the most common form of dementia, accounting for about 60 to 80% of all cases. With Alzheimer's, people tend to first notice short-term memory loss, and Alzheimer's is a slow progressive disease caused by abnormal protein buildup in the brain. And again, first notice short-term memory loss, and it is slow progression. So someone can live with this disease for 10 to 12 years, sometimes longer. And an example of someone living with Alzheimer's disease, Mary is 74 and has started asking the same questions repeatedly. She forgets recent conversations, misplaces items daily, and struggles to learn how to use her new phone. She is aware something is wrong and becomes anxious when corrected. And clues that let us know Mary is suffering from Alzheimer's disease are gradual memory loss, difficulty learning new information, and awareness of changes early on. And again, Alzheimer's typically begins with short-term memory loss and progresses gradually. And then we have posterior cortical atrophy, or PCA, which is when dementia affects vision more than memory. PCA is a neurodegenerative condition affecting the back part of the brain or the posterior part. It is often considered a visual variant of Alzheimer's disease, where brain changes affect the visual processing, but not the eyes themselves. Vision is affected because the brain cannot interpret what the eyes are seeing. So even though eyesight may be normal, PCA even though eyesight may be normal, you go to the doctor, you go to your optometrist, they're saying everything's fine, your eyes are fine. You're still seeing those changes because of the brain. With PCA, it usually begins earlier than typical Alzheimer's disease, around 50 to 60 years old. Some of the early symptoms we see with PCA include difficulty judging distance or depth, trouble reading despite normal eye exams, problems recognizing objects or faces, getting lost in familiar places, and difficulty with spatial tasks such as parking, stairs, or pouring liquid. And this is one of the we do have a video available on posterior cortical atrophy, an in-depth webinar that we did, and this is one of the links that Rachel will be sharing. And an example of posterior cortical atrophy, a 50-year-old stops driving after several near misses and says words move around on the page while she's reading. Their memory is still fairly good, and multiple eye exams are normal. So with posterior cortical atrophy, it's important that we remember that sometimes the problem is not eyesight, it's how the brain is processing vision. And then we have vascular dementia. Vascular dementia occurs due to reduced blood flow to the brain, often following strokes, causing cognitive decline. With vascular disease, we tend to see slowed thinking, difficulty planning, focusing, difficulty managing tasks, and changes in mood. Progression may be step-like, meaning that someone has a change in cognition following a stroke, and then they will stay at that level until they have another stroke and see another decline. There are a few subtypes of vascular dementia that we will be discussing next. So vascular dementia has three different subtypes: multi-infarct dementia, subcortical vascular dementia, and single infarct dementia. Multi-infarct dementia, or multiple strokes type, is caused by several small or large strokes, and each stroke damages a different area of the brain. And the key features of multi-infarct dementia are stepwise decline, again, a sudden drop and then stable periods followed by another sudden drop after a stroke. Thinking and planning are affected early, and they may have physical stroke signs such as weakness, speech changes, or balance problems. With multi-infarct dementia, families often say they got worse suddenly after a stroke. Next, we have subcortical vascular dementia, or small vessel disease. Subcortical vascular dementia is very common, accounting for about half of all vascular dementia cases, but it's often under-recognized. With subcortical vascular dementia, there is damage to small blood vessels deep inside the brain, leading to reduced blood flow and white matter changes gradually over time. Subcortical vascular is typically caused by chronic high blood pressure and aging. And the key features of subcortical vascular dementia are difficulty planning, slowed thinking, mood changes or apathy, and walking problems. Early memory loss is less prominent. This type often looks like everything feels slower. So a person thinks slower and moves slower. And then we have single infarct dementia, which is caused by a single stroke, damaging a critical area of the brain involved in thinking or memory. The location of the stroke matters more than the size of the stroke. So someone can have a small stroke or a large stroke, but it depends on the area of the brain that is affected. And the key features of single infarct dementia are sudden cognitive changes, and other symptoms will depend on the area of the brain, but include memory problems, language issues, and attention deficits. So an example of someone living with vascular dementia is Robert, who is 78 and had a small stroke last year. Since then, his thinking seems slower. He struggles with planning tasks like paying bills and gets overwhelmed easily. His decline appears sudden, then he is stable for months. And clues that let us know Robert has vascular dementia are his history of stroke, slowed thinking, and a step-like decline. And remember, vascular dementia often affects executive function first, not memory. And then we have Lewy body dementia. And Lewy body dementia has two different subtypes. And this first is dementia with Lewy bodies. And dementia with Lewy bodies is characterized by visual hallucinations, fluctuating alertness, and Parkinson-like symptoms, requiring careful management strategies. Symptoms such as difficulty sleeping, loss of smell, and visual hallucinations often precede movement and other problems by as long as 10 years, which consequently results in LBD going unrecognized or misdiagnosed as a psychiatric disorder until later stages. Later in the course of Lewy body dementia, some signs and symptoms are similar to Alzheimer's disease and may include memory loss, poor judgment, and confusion. Other signs and symptoms of Lewy body are similar to those of Parkinson's disease, including difficulty with movement and posture and shuffling walk and changes in alertness and attention. And the typical age of onset is 50 and older. So again, we were very familiar with Lewy body dementia by Robin Williams. Robin Williams, while he was alive, was diagnosed with Parkinson's disease. And then after he passed away in an autopsy showed that it was Lewy body dementia because again, we're not seeing those changes in our the memory initially. We're seeing hallucinations, changes in alertness, and maybe some movement disorder. People with Lewy body have brains that are extremely sensitive to antipsychotic medications, experiencing something called severe neuroleptic sensitivity, which means their nervous system reacts strongly when dopamine is blocked. And in Lewy body dementia, dopamine is already low. So what that means is that antipsychotics can cause sudden worsening or confusion, extreme sleepiness, severe stiffness, or inability to move, and these dangerous reactions can be life-threatening. So it's really important because of the visual hallucinations, someone might think, oh, it's a psychiatric issue and want to start with antipsychotic medications, but it can have a life-threatening reaction. And overall, with dementia with Lewy bodies, what families notice first is confusion, hallucinations, and sleep changes. And then another type of Lewy body dementia is Parkinson's disease dementia, or PDD. PDD is a clinical diagnosis related to Lewy body dementia that it can, I apologize, that can occur in people with Parkinson's disease. So Parkinson's movement symptoms develop years before the dementia symptoms. So we're seeing the movement symptoms first and then the cognitive symptoms later. People with PDD typically had an early history of tremors or stiffness, shuffling walk, and slowness of movement, and usually a Parkinson's diagnosis has already been established. Later in the disease process, a person will experience cognitive changes such as slowed thinking, difficulty with attention and organization, and visual spatial problems and memory issues. So to distinguish between the two, with Parkinson's disease dementia, movement symptoms are present for more than 1 year before cognitive decline. With dementia with Lewy bodies, we see the cognitive symptoms first and then the movement symptoms later. So if there's movement symptoms first, cognitive issues later, Parkinson's disease dementia. And risk factors for developing Parkinson's disease dementia include the onset of Parkinson's related movement symptoms, followed by REM sleep behavior disorder, which involves having frequent vivid nightmares and hallucinations. So typically, someone with Parkinson's disease dementia, the risk factors are having Parkinson's disease for a longer period of time and having REM sleep disorder. So an example of somebody with Lewy body dementia is Elaine, who is 72 and reports seeing children in her living room who aren't there. Some days she is sharp and conversational, and other days she is confused and sleepy. She also has a stiff walk and a shuffling gait. And some clues that Elaine has Lewy body dementia are the visual hallucinations, fluctuating cognition, and Parkinson-like movement. So again, we think with Lewy body dementia, fluctuations, hallucinations, and movement are the key features. And then we have frontotemporal disorders, or FTD. And FTD is a group of disorders caused by degeneration of the frontal and temporal lobes of the brain. FTD often begins earlier than other dementias, commonly between the ages of 45 to 65. I apologize, on the screen it says 50 to 60. And early symptoms frequently involve behavior and personality changes, language changes as well, rather than memory. So instead of seeing memory loss like we would with Alzheimer's disease, we're seeing changes in personality and difficulty with language. Progressions and symptoms vary depending on the specific subtype of FTD, which we will discuss over the next few slides. But some people decline rapidly over 2 to 3 years, while others can live with the disease longer for about 2 to 10 years. FTD is often misunderstood and misdiagnosed, and it can appear as stress or depression or a midlife crisis. Because it's often misdiagnosed, the changes a person experiences may seem as if they are intentional, and the family members become upset. And because of the younger onset of the disease, there's a disruption to the work and family roles. Someone may have to stop working rather earlier than they would have liked to, or they may not be able to take care of their kids that tend to be younger. And a person caring for someone with FTD often experience higher stress than those caring for someone with Alzheimer's disease. And both this frontal temporal disorders, as well as Lewy body and the posterior cortical atrophy, I have 3 separate webinars on those that Rachel will be sharing the links with you. So the first variant of frontal temporal dementia is the behavioral variant. And the behavioral variant is the most common form of frontal temporal dementia, primarily affecting behavior and personality. And symptoms of behavioral variant include loss of social filters, impulsivity, reduced empathy, and poor judgment. Individuals may show apathy, loss of motivation, or repetitive behaviors, and someone with BVFTD may do impulsive things that are out of character, such as stealing or being rude to others. They may engage in repetitive behavior, such as singing, clapping, or echoing another person's speech. And they may overeat compulsively, lose inhibitions, causing them to say inappropriate things, sometimes sexual in nature, or they become apathetic and experience excessive sleepiness. While they may be cognitively impaired, their memory stays relatively intact. And then we have primary progressive aphasia, or PPA, which is another type of FTD. And PPA affects communication and language abilities more than memory in the earlier stages. And there are 3 different variants which affect language. So the first one is non-fluent variant, which speech becomes slow and effortful and grammatically simplified. So someone with this type of PPA is going to speak incredibly slowly. It's going to take them great effort to get the words out. And they might start omitting grammar, such as the or is. And then we have semantic, which is when they have difficulty understanding spoken or written words, inability to name objects or people, and very vague speech. And then we have logopenic, which is the gradual progressive loss of word finding abilities, leading to significant pauses and hesitation in conversation, and often sentence repetition. People with this type of aphasia often exhibit slow, halting speech, frequent hesitations, and errors in speech such as substituting or omitting sounds in the words. So all 3 of these variants affect language in different ways. And what's important about PPA is starting speech therapy early, which will help the person retain some of their ability to speak. But again, with non-fluent, we're seeing speech that is slow, takes great effort to get words out, and we'll see changes in their ability to correctly use grammar. With semantic, they'll have difficulty understanding words that are either spoken to them or written down, and they won't be able to name objects. So if they see a dog, they might not remember the name of that word. And logopenic is a gradual progressive loss of word finding ability. So they're unable to find the word that they're trying to say, and that leads to great pauses and hesitation in conversations. And then we have FTD with motor syndromes. So some forms of FTD occur with movement disorders affecting strength or coordination. So we have FTD with ALS or Lou Gehrig's, and symptoms include behavioral and or language changes seen in behavioral variant of FTD, as well as progressive weakness, muscle wasting. Corticobasal syndromes include stiffness, difficulty with coordinated movement, and limb apraxia, which is a neurological motor planning disorder where the brain struggles to plan and sequence body movements. And with progressive supranuclear palsy, or PSP, a person experiences balance problems. So they may fall, they may have difficulty with their eye movements, and the most common early signs of PSP include a loss of balance, unexplained falls, general body stiffness, and depression. And a person may also experience pseudobulbar effect, which is when they suddenly laugh or cry very easily, even though the emotion is not appropriate at the time. And then we have frontotemporal dementia with Parkinsonism. Includes three core features, which are behavioral and personality changes, cognitive impairment, and motor symptoms. People with this type often have hallucinations, and slow of movement and tremor as seen in Parkinson's disease. With FTD with motor syndromes, it's important for a person to start physical therapy and speech therapy early in the disease process for it to be most beneficial. And a couple different examples of FTD. For the behavioral variant, a 59-year-old man begins making inappropriate jokes in public, overeating sweets, and losing interest in work. His memory tests are normal, but his personality is different. So with the behavioral variant scenario, it shows us that behavior changes can be neurological, not psychiatric. Because again, we're seeing this changes in his personality and his memory test is normal. With primary progressive aphasia, a woman in her early 60s struggles to find words and pauses frequently when speaking, but manages her daily task well. And this shows us that language decline can be the first symptom of dementia. And can be a little bit tough because we do see difficulty finding words with someone with Alzheimer's disease. However, with primary progressive aphasia, that memory, that executive function stays intact while it would be affected with Alzheimer's disease. And then when we have a motor variant, a person develops stiffness, falls, and difficulty coordinating movements along with changes in judgment. And this shows us that some dementias affect movement and cognition together. And overall, with FTD, it's important to remember changes in personality, social behavior, and language are the key features. And next is mixed dementia. Mixed dementia occurs when two or more types of dementia are present, leading to varied symptoms and challenges. Mixed dementia is very common and often underdiagnosed. Autopsy studies looking at the brains of people who had dementia suggest that a majority of those over the age of 80 probably had mixed dementia caused by both Alzheimer's disease and vascular disease. In one study, approximately 40% of people who were thought to have Alzheimer's disease were found after autopsy to also have some form of cerebrovascular disease as well. So again, when we talk about mixed dementia, the most common two dementias mixed together are Alzheimer's and vascular, but we will see both symptoms and they can widely vary. So someone living with mixed dementia is Dorothy. She's 83 and shows memory loss typical of Alzheimer's, but also has difficulty with attention and problem solving. She has a history of high blood pressure and small strokes. So some clues that we see for Dorothy is that there's overlapping symptoms. She has memory loss, but she's also having difficulty with attention and problem solving. She has vascular risk factors such as high blood pressure and small strokes, and there's the mixed progression patterns. So what we want to remember for our four types of dementia, because again, there's overlapping features for all four, but how we distinguish them matters. So with Alzheimer's disease, the key indication is memory loss comes first. With Lewy body dementia, awareness and perception occur first. So again, perception is how the brain interprets what the senses take in. So we'll see hallucinations, misinterpreting shadows, difficulty in judging what is real and what's not. And the awareness is how alert, connected, and mentally present someone is. So with Lewy body dementia, we'll see someone who may be alert at some times, not alert at other times, and their perception of how they take in the world is off. With frontotemporal disorder, we'll see changes in personality and behavior first. And with posterior cortical atrophy, we'll see issues with visual processing first. And then there are a few rarer types of dementia. First is Huntington's disease. Huntington's disease is inherited, caused by a single defective gene, which is dominant. So anyone who inherits it from a parent with Huntington's will eventually develop it. And Huntington's is caused by a protein buildup of Huntington, which the function is not known. Symptoms include confusion, memory loss, hallucinations, and difficulty with coordination. And then we have Creutzfeldt-Jakob disease, which affects about one person in every 1 million per year worldwide. So it is very, very rare. And it can resemble other brain-like disorders, but progresses much more rapidly. Symptoms include personality changes, anxiety, memory loss, impaired thinking, and blurred vision. And then we have chronic traumatic encephalopathy, or CTE. And this is one of our newer dementias that we've been talking about lately because of repeated head trauma that football players and wrestlers are experiencing. CTE is a degenerative brain disease caused by repeated hits to the head, sustained over periods of years. It's been found in veterans, victims of domestic abuse, and athletes in boxing, football, soccer, and ice hockey, among others. With CTE, it can only be diagnosed after death through a brain tissue analysis. And some symptoms include difficulty thinking, impulsive behavior, depression, short-term memory loss, difficulty planning, and emotional instability. And with CTE, this is why it's so important that our kids are wearing helmets when riding their bikes, especially the e-bikes. It's all of the craze right now. Tell them to wear a helmet. And then we have Pick's disease, which is a very rare form of FTD, and it's caused by an abnormal buildup of tau protein leading to Pick's bodies and cells in the brain. It affects the frontal lobes of the brain and is a progressive form of dementia, causing severe behavioral and personality changes and language difficulties. So those are our progressive forms of dementia, meaning that unfortunately there is no cure for those types of dementia. They will continue to progressively get worse over time. But what we also have is reversible causes of dementia. So again, dementia is a group of symptoms: memory loss, changes in our thinking, difficulty planning, and we can say what causes those changes, and it may be something that is going on in the body, but it is reversible. It can be due to a medical or psychological condition, and we can find that when treated early, symptoms may improve, stabilize or resolve completely. And some common reversible conditions include vitamin deficiencies. So, for instance, iron, vitamin B12, vitamin D, untreated thyroid disorders, medication side effects or interactions. Sometimes people are taking a lot of different medications prescribed by a lot of different doctors with no real oversight to those medications. So they may be taking medications that interact with one another. Maybe they're taking medications at the wrong time of day, so they are seeing changes in their cognition. Untreated depression can cause the symptoms of dementia. Sleep disorders, such as sleep apnea, and infections, such as a UTI. With urinary tract infections, we might not notice the symptoms like we did when we were younger, and an infection left untreated could wreak havoc on our cognition. So, with these reversible conditions, what happens is once they are diagnosed and treated, we return back to our baseline. But what's also important to know is that if our loved one has a irreversible type of dementia, Lewy body or Alzheimer's disease, and they also develop one of these reversible conditions, we may see a significant change in them. And it's important to be on the lookout for that because sometimes people think, oh, my person's acting different, but that's normal. That's what's supposed to happen with the Alzheimer's disease. But really, what's going on is that they have a urinary tract infection or they're dehydrated and it's exacerbating the symptoms of their already established dementia. So, just to be very mindful that anything going on in the body can definitely affect the brain. And then we can also experience medication-related cognitive changes. So, anticholinergics are medications that block the action of acetylcholine. And acetylcholine is a chemical messenger in the brain and body, which is important for memory and learning, attention, muscle movement, bladder control, digestive. It does a little bit of everything. But some medications actually are anticholinergics, such as Benadryl, over-the-counter sleep medications, some bladder medications, some antidepressants, motion sickness medications. And what that's doing is blocking the release of acetylcholine, which we will then see issues with memory and learning. So be very mindful if you're taking any over-the-counter medications that you're always talking to your doctor about those first. Some sedatives, pain medications, and again, polypharmacy. If we're taking too many medications and they're interacting with one another, that might be causing changes in our cognition. And what we see is that older adults are more sensitive to side effects than when they were younger. So it's so important that we are getting medication reviews done routinely. You can take it to your doctor, but what I always recommend is your pharmacist. They're a wonderful neutral third party. It's a free service that they do. They'll look over your medications and make sure that you're taking everything at the right time, the right dose, that nothing is interacting with one another. I once had someone who was taking both a high blood pressure medication and a low blood pressure medication because she didn't realize she was supposed to discontinue one when she left the hospital. So we often see this where people maybe are not fully aware of any changes in their medication, especially with a recent hospital stay. So I always recommend just going to your pharmacist to make sure that everything is as it should be. And always talk to your doctor before starting an over-the-counter medication, no matter how simple it may be. And it's important to talk to your doctor and push for further evaluation if you see a sudden or rapid decline in your loved one, if symptoms that fluctuate dramatically, if after an illness or a hospitalization or medication change, you see significant changes in your loved one, or you're experiencing cognitive changes without a typical pattern. So again, most are going to be a slow progression down, but if you start to see that there's been changes that aren't normal for your loved one, talk to your doctor about that. And let's revisit why an accurate diagnosis matters. After all of that information, you can see that each type of dementia is so different and how it affects the brain is very different. When I first started my career 20 years ago, everybody had Alzheimer's disease. That was what it was. You had Alzheimer's disease and you were nice, or you had Alzheimer's disease and it was very complicated and you could be aggressive. But we didn't distinguish between Alzheimer's disease and Lewy body disease. We just didn't do that. But now that we know all of these different types of dementias exist, we want to talk about it. So many families assume all dementia is Alzheimer's disease, but in reality, the underlying disease changes how we communicate, how we manage behavior, and plan for the future. The symptoms that someone's going to experience, the progression of the disease, and the care needs that person is going to need are going to vary from dementia to dementia. And what's important is that some causes of cognitive decline are treatable. So we do need to go to the doctor and express our concern because there may be something going on in our body that we can be rectified. And diagnosis helps our families plan and make informed decisions. When you know what's going on, you can start planning for the future. And this leads us to a comprehensive diagnosis, which is so important. A person should never go to their doctor for a quick appointment and leave with a diagnosis of dementia or medications for dementia. It's a very long process and usually involves many different doctors. And the first step should be a very thorough history and physical, talking about current symptoms, when do they start, how have the symptoms changed over time, is there medical or psychiatric history that needs to be taken into consideration, is there any family history, and what are all of the medications that that person's on. And it's important that a family or a care partner go and talk to the doctor about the history and physical as well, because sometimes what happens is that a person experiencing dementia may not be fully aware of all of their symptoms. They may think everything is okay, and so they're not reporting to the doctor what's actually going on. So, as a care provider, giving that input is going to be essential. And then there's going to be laboratory tests. We should be checking urine, we should be checking white blood count, looking at our vitamin B12 levels, A1C. We should be doing a real comprehensive lab test. And then we should be doing MRIs, CT scan, a PET scan to see how is the brain functioning. Certain tests can show us if there's plaque buildup, tau. So it's important that we want to get those tests done as well. And then from there, a referral to a neurologist for in-depth testing. And this is going to be testing that looks at all of the different areas of the brain, memory, attention, visual spatial skills. And this is the testing that is hours long. And it's important to remember that a comprehensive diagnosis is looking at the whole person. It's not just about a person's memory, because someone's memory can be fine, but they're experiencing all of these other symptoms indicative of another type of dementia. So again, it's a very extensive process. One of the sheets that I've asked Rachel to share with you is a comprehensive diagnostic checklist that you can help facilitate a conversation with a doctor. Because again, we want to know exactly what's going on with our person so that we can take better care of them. But unfortunately, all of these dementias are still relatively new, and our primary care physicians may not be as well versed as a neuropsychologist. But ultimately, again, someone should never walk into their doctor's office for, let's say, an annual visit and walk out with a dementia diagnosis. And if your loved one only has a dementia diagnosis, more testing needs to be done to figure out the specific type of diagnosis. Because again, diagnosis is going to aid how we provide care for our loved ones. With Lewy body dementia, we know to avoid certain medications. Typical medications that are given for Alzheimer's disease, such as Aricept, should not be given to someone living with Lewy body dementia. And it's important that that person knows that so they're not taking that medication and that the doctor's not prescribing that medication. With frontotemporal dementia, behavior strategies and physical therapy are essential very early on in the disease process. Families need to understand the behavior changes and learn how to communicate successfully with their loved one. With vascular dementia, managing blood pressure and stroke risk is going to be critical. Because again, someone with vascular dementia, they have a stroke, but they're able to stay at that new level as long as they don't have any changes either by blood pressure or stroke risk. So making sure you're on top of that is essential. And with Alzheimer's disease, memory and orientation support are key. So again, all of these different types of dementia require different ways that we care for them. And without a diagnosis, we have uncertainty about the symptoms. We may be misinterpreting the behaviors. We may think that they are intentional or psychiatric or something's going on with our loved one. And we might experience increased stress and conflict with our loved one. But with a diagnosis, we have realistic expectations of what the disease is and what the progression of the disease is going to be. We're able to build better communication strategies with our person. We're able to plan for the future and plan for the progression of the disease. Because with all of the dementias, the most important thing is that we begin planning right away and planning for the future via advanced healthcare directives, power of attorneys, establishing trust, establishing what their wishes are for their future. And all of that needs to be done at the beginning process of the disease. But with Alzheimer's disease, which is a much more slow-moving disease, there might be a little bit more time versus a Lewy body dementia or a frontotemporal dementia. And when we have a very specific and accurate diagnosis, we can seek support sooner. We have a wide variety of support groups between Caregiver Resource Center of Orange County, Alzheimer's Orange County, Alzheimer's Association of Orange County, but they're typically for Alzheimer's disease. And it can be very frustrating for a care partner who's taking care of someone with frontotemporal or Lewy body because you're not experiencing the same things. But when you know what your loved one has, you can seek out a designated support group. So for instance, we offer a support group for frontotemporal and Lewy body. And for the person living with the disease, a diagnosis helps to validate that their symptoms are real. Sometimes it can feel like they're going crazy because all of this is happening and they don't know why. But it allows for them to say, okay, I have this disease. What I'm going through is normal. It reduces self-blame. Sometimes we think that we caused this to happen, but understanding that it's a diagnosis and it's the changes in the brain and it's outside of our control. And for the person living with the disease, having a diagnosis and understanding what the disease process is, it allows for participation in decisions early on. So it gives them an opportunity to talk about what they want, what's important for them, and how they would like to live the rest of their lives. And for families, we get a relief in understanding what is happening, right? And especially with Lewy body or frontal temporal, primarily frontal temporal, it can be this, what is this, right? My loved one is all of a sudden doing a 180. They're completely changing their personality, and I don't understand why. And it can be very frustrating. And again, we can plan for the future better together. And a diagnosis doesn't just change the disease, right? But it changes how prepared, supported, and empowered of a family that you can be. It leads to education programs. You know what to seek out. You know what you need assistance with. It can lead you to support groups to help you find those that are in similar situations as you, and a place for emotional support and help relieve stress, community service and care planning resources. And it also offers the opportunity for clinical trials and research opportunities if that's something that you are interested in. Because in order to participate in a clinical trial, you will need an official diagnosis for that. And a saying that I like is a diagnosis changes everything and it changes nothing. It allows us to understand symptoms, access resources and support, and learn communication strategies. And it's assist us with planning and decision making, but it does not change the person's identity, their need for connection, and their value and dignity. A diagnosis gives a name to what is happening, but it does not change who someone is. So, our key takeaways for today, and I know it was a lot of information that we covered, but I do have a lot of resources coming your way through Rachel that look at all of this in a little bit more depth. But it's important to remember not all dementia symptoms are permanent. It's important to figure out, is this a reversible type of dementia or an irreversible type of dementia? And while Alzheimer's is common, it makes up for about 60 to 80% of all Alzheimer's cases. It's not the only cause of dementia. And some conditions, again, are treatable or reversible. And early evaluation empowers better care and better advocacy. So it's so important. Any concern that you have, that you are talking to your doctor, putting aside that fear, putting aside, what if it is and what if it isn't, and talking to your doctor is a great first place. Okay. So now, Rachel, I'm happy to open it up for questions.
Perfect. Thank you so much. That was really good information and a really good overview of all these different diagnoses that I don't think everyone's familiar with. And it's really good for us to know and how to get started, where to turn. So thank you. And there are a couple questions that I see in the chat. The first one is there anything you can tell us about late, LATE, a more recently identified type of dementia, and how to differentiate it from Alzheimer's?
Yeah, let me rack my brain on that one. Dementia. Yes. Um, I'm actually just looking it up too, because it is so limbic, predominant age related. Okay, so it has the TDP 43, which shares the pathology, the protein as Alzheimer's disease. I will have to look that one up a little bit more in detail for you, and I'm happy to share those resources with
Perfect.
Rachel because that is one that is there in my brain, but I'm having a hard time pulling it out.
No problem. That's perfect. And that's where what we'll do too is when we send out all these resources to everyone, I'm also typing, any answers that come up to these questions, and we'll send that information out as well. And another question is regarding vascular dementia. They're asking, how reversible is it, especially if it occurs from a stroke? Is it inevitable to progress even if the person significantly recovers?
So the damage done by the stroke will remain. Now, therapy and getting early interventions into place can help a person live successfully. So, the highest risk factor for having another stroke is already having a stroke. So, it's very important to reduce your risk of developing another stroke. So, I want to see if I can look at that question just so I can make sure that I answered it completely. So, with vascular dementia, it is not reversible, um, but it is possible to not have further progression. So let's say someone has a stroke, they go to physical therapy, speech therapy, and they improve, but there's still that decline. They can stay at that new level as long as they don't have another stroke. So again, it's so important that if you have a stroke, you're taking your aspirin, you're taking your blood thinner if appropriate, you are monitoring your blood pressure routinely, all of those things to help prevent a future stroke or a future high blood pressure.
I think that's very helpful. And then just kind of a follow-up to that is, can someone fully recover from a stroke, or will there always be maybe some type of cognitive issue, or is it possible that there's no cognitive issue after a stroke?
Right. And it all depends on where the stroke affects the brain. So it's possible to have a stroke and have no cognitive issues from that stroke. Maybe there could be someone has a stroke and they might have physical symptoms, or they had a stroke and they have absolutely no symptoms whatsoever because the area the stroke hit didn't affect memory or didn't affect language. They received medication early enough. That's one of the most important things about experiencing a stroke is getting to the hospital as soon as possible for medication. So not every single stroke is going to lead to vascular dementia. It all depends on where that stroke affected the brain.
And that was very helpful what you said too about, um, the impact is really where the stroke happens, not necessarily the severity of it. So I think that was really interesting to learn as well. Any other questions that anyone has? We have about 2 minutes left. Any other questions? And if you want to type it in the chat, you can, or you're welcome to just unmute and ask a question that way as well.
I'm gonna just real quick, as
Sure.
people think of their questions, I just wanted to share our resources as well. We offer support groups, education, um, and all of the wonderful resources that Caregiver Resource Center of Orange County is offering, we offer as well to help support. It takes a village, as we all know. So if you have any questions, you can call our helpline. And I do see that there's another question, is Alzheimer's disease hereditary? That's a big answer. So with Alzheimer's disease, what we see is that there is essentially a 50-50 risk. You can develop Alzheimer's disease through a genetic component, the APOE4, but just because you don't have but just because you have the APOE4 gene doesn't necessarily mean that you're going to develop Alzheimer's disease. What we see is that lifestyle factors matter so much more, and maintaining a healthy lifestyle reduces the risk of Alzheimer's disease. However, there are some for typically the younger onset of Alzheimer's disease, 65 and younger. We do see that there is a strong familial tie. So we'll have your person, your loved one, like let's say, your mom had it and her sisters had it, that we do see that hereditary aspect, but there is a strong genetic component, the PSEN gene in that. So it's very important, regardless of your family history, maintain your six pillars of healthy living. And the best first step for an accurate diagnosis is going to your doctor. That you need to go to your doctor and getting lab work done. And again, Rachel will send out the checklist of everything we recommend the doctor test for, but that will help with a good starting place as to what your next step should be.
Perfect. I think that's a great place to start and to have that information. And then also for Alzheimer's, Orange County, of course, it's not necessarily the same level of assessment as, a neurologist or other neuropsych situation, but are you all still offering memory screenings? And then how would somebody access a memory screening with you all if they're kind of not sure or not really, just wanting that maybe additional support?
Yes, perfect. Thank you. So
Uh-huh.
we do offer memory screens to the community. It's a very quick 15-minute test, just to see how is your memory functioning, if there's any possible concerns, and how you can talk to your doctor. It's not a diagnostic tool by any means, but you can call our helpline and they can go ahead and schedule one for you.
That's such a great service to the community, and I think maybe a little bit of a less scary thing, to just kind of have that ease in and then that support and okay, how do I navigate trying to have this conversation with my doctor? Where do I go? So for those of you on the call, please don't hesitate to reach out to Alzheimer's Orange County, utilizing their helpline or any of their other wonderful services that are offered. And we really appreciate you all taking the time to be here this morning, now afternoon, I should say. And especially Lauren, thank you so much for your expertise, your willingness to share this really vital information in a way that was digestible for my brain. And so thank you very much. And just so everyone knows, when you close out of the Zoom call, there will be I think it's 3 or 4 questions, a brief survey about the class and what classes you'd like to see in the future and any feedback that you have. I will be sharing that, of course, with our presenter as well. But that's all from me. Anything else, Lauren, that you'd like to add before we jump off the call?
No, thank you everyone for joining us today.
Wonderful. Thank you, everyone. Have a great rest of your day. Take good care. Thanks, everyone.